Welcome, 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 my Be Health Empowered family, to another episode of Excuse Me, Doctor. I'm Dr. Melissa Clark. I'm delighted to be here with you today. And of course, you always can call me Dr. Mel. And I'm welcoming all our newbies that are tuning in for the first time. This show is specifically to empower our listening audience when it comes to making informed decisions about their health, their family's health, and even the health of their entire community. So join us on this ride that we take every week. We're so happy that you're tuning in. If it is for the first time, please remember to go ahead and hit that subscribe button if you're checking us out on YouTube. And if you're checking us out on Facebook, please hit the like button. We really, really, really super appreciate you for doing that. We're here specifically for you so that you can get your comments, your questions in. So we got this chat, right? You got it on YouTube, you got it on Facebook. Please make sure to put your opinions and your questions, most importantly, in there so that we can get to them as we go through the show. And I can't do this alone. I really can't. I have to have two really key people who are here with me every single week, Lila Mays and Wayne Bruce, my co-hosts. How y'all doing?
What's up, Dr. Mel?
Hey. Happy Monday, everybody.
Happy Monday.
Hey, Lila. I'm trying to get my mic straight here.
We can hear you.
How you
we
doing,
can hear
Lila?
you.
I ain't seen
Good.
I like the orange hat.
Yeah,
Thank you.
Thank you.
Yeah.
Oh, I thought you was talking about my hair.
No. But I like your pink shirt. It's very springish.
It's springish.
It's
Spring is
springish.
here.
Absolutely.
I decided to coordinate with the studio vibes here. You know what I'm saying?
I see. And we are blessed once again tonight to do our once monthly joint show where we co-host with the Howard University Research Centers in Minority Institutions Community Engagement Core. Try to say that 15 times.
Great.
And,
I don't know how
and representing Howard University, we have Karen Parker. And would love to see her come on camera. There she is. Hey, Karen. How you doing?
Hi, everyone. Blessed Monday. Happy Monday to everybody. Good to see you again.
What's up, Karen?
Yes.
Hi.
Great.
You gotta be high energy for this show, Karen. You gotta be high energy.
She got that beautiful. She has that beautiful
with
winning
the low
smile.
energy. We don't need low E Karen. We need high energy Karen.
Here I am.
We got her. So Karen is the project coordinator at the Community Engagement Core in the Research Centers for Minority Institutions. She's going to tell us a little bit about what they do and what Howard University, this collaboration, helps to do to promote research.
Thank you again for having me. It's always a pleasure every month to do this conversation with you all. So I feel very humbled to be here. What we do in my section of the RCMI, which was called the Community Engagement Core, is we do a lot of listening. We sit down with our community partners like Dr. Melissa, and we collaborate with you to get a sense of what is important, what is key, and what you would like to see us answer in our research. And in turn, what we do is make sure that the RCMI sponsored research that we do speaks to the needs of our neighbors. So it's a lot of back and forth, it's a lot of listening, and that's why we have 2 ears and 1 mouth.
Well, that's a beautiful thing. And we are so glad that you're joining us because Howard University always makes sure that we have excellent guests for this episode. And tonight we have an incredible topic that we're talking about. Maybe one that a lot of people don't want to talk about, but it's so important. And that's what we call end-of-life care. Because whether or not we want to face it, it's something that's important to know about what our choice are as we might be approaching the end of life. So how do we remain health empowered, even in the face of what we call a life-limiting illness? We have an incredible guest who's going to join us. and is going to really guide us through key topics like advanced care planning, how to communicate with your healthcare provider around these issues, understanding what your treatment options are, what are the emotional and spiritual supports available. We're going to cover it all with this incredible guest. So without further ado, I am going to bring on Dr. Melissa Mosely. She was a Howard University College of Medicine graduate. She completed her residency in internal medicine at the Allegheny Health Network in Western Pennsylvania. And as we speak, she is doing a fellowship at Yale for palliative care and hospice medicine. So thank you so much for joining us, Dr. Mosely.
Hang on.
And I'm really excited to talk about palliative care medicine and how it impacts our community.
Well, before we get started, I just want to hear a little bit about you. There's so few doctors of color who choose this specialty. What led you to it?
So I think it's more of a personal reason. I am someone like you or like anyone who would be watching this stream who has many loved ones. And something that is common to every human being is the fact that we are going to eventually come to end of life. And at the time that this happened for me, it was a family member that I have who's actually also a Howard U grad. And I think it was just really seeing the process of how she passed away and realizing that we really, not just me, not just my aunt, my entire family really needed someone to sort of reach out, embrace us, give us extra support and answer questions we just didn't have. Mm-hmm. And a lot of the doctors, you know, you just highlighted something beautiful. We have a beautiful collection of brown-skinned people here right now, but most hospitals, unfortunately, don't look like that. And it can be very alienating. So if I am able to stand in that gap and just be one more positive, affirming voice for other people of color who are asking questions about end of life and related issues, then that is my goal, and that is my mission, and that is how I wound up in this field. So yeah,
wow.
It's just,
thank you. Yeah. Thank you so much for that. As an emergency physician myself, I have seen so many people in the emergency department who come in, and in the absence of any direction, we have to do the most. And it's not always called for. It's not always pleasant. It's not always successful. And it takes a toll on the family. And so I thank you for doing what you do. And, you know, this is going to be a conversation. So I know there are other, we're going to have other folks ask questions, my wonderful co-host. So Lila, take it away.
Well, I'm going to start, Dr. Mosely, with if you could give us an explanation of what palliative.
I think the question was, what is palliative care? Is that correct?
Yes.
Yes.
That's correct.
Okay. So that is an excellent question. What is palliative care? So as Dr. Clark mentioned previously, I did my internal medicine residency, and then now I'm subspecializing in palliative medicine, which is sort of an added layer of support. We work with your other medical team members, with your primary care physician and any other subspecialists that you may be seeing to help patients who are facing life-limiting illness or who are struggling with symptoms from serious illness to overcome those symptoms or to be more at peace and to be more comfortable. Now, we accomplish that not just by using medical means, but we function as an interdisciplinary team with a chaplain. We have a social worker most of the time as well, and a palliative care trained pharmacist who back up our physicians, because this is really a team-led effort. In the same way that you see the human spirit is expansive, so is medical care, and so should it be. And that is our philosophy in palliative medicine.
Okay, you answered part 3 of my question about what makes up the palliative care team. So thank you for that. So pharmacist, clergy person, I think I heard you say. And who are the other members of that team, doctor?
So social work, usually we have a social worker or a care manager, yes, who focuses specifically on financial support, emotional and therapeutic support as well. They can also offer therapeutic presence for some patients. That's all they require. But, and then leading that team, or really sort of at the head of that team, would be a medical provider. So that could be a physician, that could be, an MD or a DO, that could be a nurse practitioner, or that could be a physician assistant. But more often than not, it's all of us working together to meet the patient's needs.
Okay, great. So when do doctors typically speak to patients about palliative care?
That is an excellent question. I think it really depends on the subfield, but I would say that definitely providers who are in fields that deal with patients with serious illness, such as cancer or heart failure, lung diseases like COPD or emphysema, those are the typical types of providers that would refer for palliative care. And honestly, there are different criteria that each subspecialty uses, to make a medical decision. But sometimes it's not really about just the medical pieces and what all the numbers are saying within our field. So if a provider sees someone or a chaplain is visiting with a patient, a social worker makes that visit in the morning, and they're noticing that this patient is someone who's got a financial issue, or they're experiencing existential distress or anxiety as a component of their illness process, then that's a time that you would maybe consider referring for palliative care, because we can help with those things.
All right. My next question is, what is hospice care? And this is a triple parter as well. So what is it, and how is it different than palliative care? And then who would be on a hospice team?
So that's, again, you're asking all the right questions here. So
Okay.
palliative and hospice medicine, I think a lot of people conflate because they are both focused on symptom management and, providing bereavement services, things of that nature. But hospice is really a government sponsored benefit for it goes through your insurance. And effectively what they do is they provide services to patients who are at a point with whatever their disease state is, whether that's a terminal disease, it's generally a terminal disease. And we're anticipating that if we have no further treatment options, that naturally, if we allow things to pass and progress as they would, without our intervention, the patient would pass away within 6 months. Now, palliative care is able to provide supportive presence, medication therapy, anything that someone would need alongside your receipt of treatment. So you can get chemotherapy and radiation and surgery and still have doctor. And once you transition to hospice, really that last 6 months of that terminal illness phase, that's when you would make that sort of transition over to hospice. So both very focused on symptom management and providing supportive care, but hospice is more for patients who are at end of life with no further treatment options available.
Got it. Thank you.
Okay, thanks for clearing that up, because I'm sure we all had that question. I would like to kind of go backwards a little bit and find out why do you think that it's important for us to know about all of these various options?
Well, it goes back to the fact that all of us, every person that's breathing the air and was underneath the sun today at some point, each one of us is going to pass away. And I think a lot of times in medicine and as a society in general, we focus more on what our quality of life is. And people are really hesitant to talk about end of life issues and the process of death and dying in and of itself, because it's scary and it's something that's unknown. There are a lot of different variables. The quality of death is not something that we do consider. We consider quality of life very much. We think about what kind of house do I want to have? What kind of car do I want to drive? But talking about those unknowns can be very frightening, well, frankly, for a lot of people. And that's why I think a lot of times these conversations aren't happening until it's really an emergency and we're sort of in a crisis state in some instances.
I love that you brought that up, that we wait until we're in a crisis state to discuss it, when really the best time to sort of make those decisions are when you're not in a crisis state, right? So thanks for making that distinction. What are some of the options that palliative care has to address the pain and the other symptoms like anxiety that people have who have advanced illness?
So we do a lot of different things, and I think people tend to just associate palliative care and hospice medicine with the use of very intense, heavy pain medications, but really we see pain as a multimodal issue. So we have this concept we talk about called total pain, where we're addressing not just the fact that you are suffering with physical pain from whatever illness state that you're in, but on top of that, there is that dread, there is that anxiety, that fear about what's going to come next. So again, because we have that interdisciplinary team, team, we're very fortunate in that we can ask for support from our clergy people, we can ask support from our social work team, and then also if you're in a situation where you have access to things like massage or Reiki, we also employ integrative medicine as a big component, especially for anxiety management.
Right.
It's a non-pharmacologic way, it's a non-tablet way of trying to help people manage their symptoms, because a lot of times I think patients, they have so many medications they're already taking anyway, and then here I come along saying, okay, here's this pill, you're going to have to take this every 6 hours by mouth and drink water, and it's overwhelming for people a lot of times. So we try to focus on non-pharmacologic measures in addition to those medications, but we try to balance those two things out to provide you the very level best care that we can, however you need it, wherever you are in your journey.
Right. Okay.
No, that's very helpful. I'd like to, again, step back and get a sense of when or how can a patient start that conversation with their care team about how much more time they have and what the care team's goals might be.
So that's a very interesting question. I think that is something that is deeply personal, and it's going to vary it varies based on what the patient is suffering with. But in terms of when it's appropriate to ask about end-of-life care, that's something that even as a 34-year-old person, I would advocate that we all do, regardless of your age, because at the end of the day, unfortunately, traumas can befall anyone. And when you're not in a position where you can make those decisions, it's going back to exactly what Dr. Mel was saying a few minutes ago about that crisis point. You don't want it to come down to a moment where, it's 2 a.m. and this is a real example of something that happened when I was in residency. We were trying to navigate a conversation about whether or not someone's mother should go on the breathing machine at 2:00 in the morning, and the family was just completely blindsided, and they didn't understand really what it even was that we were asking them to do and what the implications of that were. So, the big picture is that you want to try to initiate these conversations as early as you are comfortable with. And it could be any provider, your primary care doctor, for example, or if you're seeing a GI specialist for stomach issues, a heart doctor, anyone should be able to have this conversation with you. Any physician should be able to, or any provider.
Right. And you bring up that really key point about, trauma can befall any of us, and we can end up in a situation where, it's going to come down to how aggressive is the treatment that we get versus deciding on comfort care. So that can happen in trauma. It can happen if somebody with a more chronic disease like heart failure or cancer. So when should patients consider, when deciding to pursue aggressive therapy versus non-aggressive therapy?
That's a very, very good question. And again, this is a really individual, deeply personal question. I think how much someone is willing to go through in order to get curative sometimes, or maybe even just suppressive treatment for whatever condition that they're struggling with. Everyone sort of has a different threshold for that. But I would definitely say if someone is in receipt of a serious diagnosis, such as Lou Gehrig's disease, or like you mentioned, cancer, heart failure, it's honestly appropriate for you at that point in time to start making those decisions, and to start sort of investigating with the providers that would be providing those would be completing those interventions for you, so that you can have a general sense of what the future might look like. Because especially with our heart failure population, we tend to think, what is the natural extent that this disease could go to before we start talking about end of life care. I mean, and this is everything from medical therapy to device placement with an LVAD, or any one of a variety of different
That's an artificial heart pump.
Exactly. An artificial heart pump.
Yeah.
We can do that, or there are a variety of things we can do, but all of these are invasive and pose the risk of either injury, infection. There are a lot of complications that come with that. And some patients are just not comfortable with proceeding with something going that direction, whereas others will do anything that they can to survive. Now, about preparation planning, it's realizing at the outset that we are going to be suffering with this serious chronic illness. It is eventually going to take my life. How long it is between here and there, I'm not sure, but at least let me use this time I do have. That's a good time to try to set down a plan for myself and for my family, so my voice is heard even if I can't speak at that point.
Wow.
Right.
I think I got to jump in because this conversation is not triggering for me, but I've recently gone through last year, 2023, burying my dad and watching him go through end of life with cancer. But before that, about 18 years ago, 17, 18 years ago, I dealt with a palliative care team for the first time ever. I hadn't heard of it, right? Hadn't heard of it. And I don't know if they had heard of Black people, just because the way we were cared for, and in a manner we were cared for. And it wasn't a great interaction. My sister passed of glioblastoma, and she was diagnosed, and very at 18 years ago, there no treatments. Nobody lived past 12 weeks or 10 months was the longest, and it was like written up in a book, like 10 months. And this is before Ted Kennedy and all that. And I'll try to get through it, but how that team, I think they put the most, I guess they were trying to be comforting, but it was the most morbid team, and they couldn't relate to my sister's wishes. My sister's wishes were to revive me at all costs. And they kept saying, hey, well, it's this kind of thing. You're going to pass away and all that. She was like, okay, these are the wishes, though. Well, it's going to hurt. Do you really want that to hurt the people? And I don't think we made a cultural connection and really her wishes. That's really important. And so my question stems from that. How can we make sure we receive the kind of care we want, whether it's spiritual, culturally, or if we're ever in that situation, we can't speak for ourselves, because she lost the ability to speak. And so it was just the family trying to communicate the wishes.
Right. And I just wanted to add, just so that everybody knows, glioblastoma is a kind of brain cancer. And so when Wayne says that his sister lost the ability to speak, it was because the cancer had affected her speech center.
Yeah.
I mean, wow, Wayne, I just want to start off by saying I'm sorry to hear about your father, and it is abysmal what you said about how your sister was treated as well. I am so sorry that you experienced, that you've had these things happen. And especially, I want to revisit what you said about your sister, especially. About 20 years ago, it's funny, that's about when palliative care became a subspecialty and was recognized by the American College of Graduate Medical Education. And it was the first time that they'd ever tried to create a standardized protocol for any aspects of palliative care, because before that, people were kind of running roughshod, doing whatever they thought made sense in the moment. But we didn't have an organized schema to think about how we should be considering the different aspects of end of life for each of our patients at an individual level. We did not do that as a field very well. Unfortunately, I feel, and I'm not trying to blame anyone here, but I do feel that there is that lack of cultural understanding, just like in any other area of medicine. That's part of the reason that I'm here right now, is really just getting the word out there and trying to explain that, palliative care shouldn't hurt. Medicine is not supposed to ever hurt you. And the fact of the matter is that, culturally, I think, and spiritually, religiously, Black people, African-American people in general, we are just such a deeply connected and deeply rooted spiritually community. And that as a result of that, a lot of people in medicine have this very antagonistic sort of attitude to that, or this idea that, oh, miracles aren't real and God's not real. Well, I'm sorry, maybe you don't believe that. But that is a part of my cultural value system, doctor. You need to take, a lot of providers, I don't do a great job of stepping back outside of themselves and meeting patients and meeting families where they are. The fact that your sister's wishes, I mean, that's distressing. That's the sort of stuff that keeps me up at night, because you're right. These can be difficult or morbid conversations sometimes. I'll admit that. And it is very hard. But at the end of the day, in palliative care, the perspective that we have these days is really centered on making sure that your wishes are met. I promise every single patient that I meet, and this is true, my first time meeting you, I just established that it is not important what I have to say. I'm here to be a conduit for you. How can I get you whatever you need and whatever you find acceptable in terms of treatment? And how can I make sure that other people that are other physicians, other providers, other social workers, nurse practitioners, whoever, everyone that is taking care of you needs to understand that these are your wishes, or these are your family's wishes, and there shouldn't be contention around that. That's totally inappropriate, because at the end of the day, do no harm also extends to meeting someone's wishes. I mean, because if you perceive it as harm and I'm doing it to you, that still counts as harm. It's not my narrow definition of what harm is. It's yours. And I'm here to try to honor the wish that you have of making sure that you have the quality of death and the quality of life that you find acceptable, whatever that means.
Let the congregation say amen on that.
Amen. Right.
How many more of these Dr. Mo's can we get out here?
We're
How
gonna
many
rename
more?
you Dr. Mo now.
Right.
No.
And I know Karen is kind of signaling to me that she wants to get in a question about religion and spirituality, since we're on that topic, right, Karen?
Absolutely. Because from a cultural perspective, when these conversations start to happen, invariably there's going to be at least one or a consensus of family members that say, you know what, we're just not ready to have that kind of conversation. We're just going to leave it over to our God, and we'll let our Redeemer take the wheel. How do we navigate and come to a consensus and come to a level of mutual understanding when that's the topic that enters the room and the discussion?
That is such a good question. And I want to say, oh, here's the answer 100%. But a lot of what we do is so case-based. And I think that people's faith and spirituality is another one of those unique instances that we have an opportunity to meet the patient sort of where they are and meet that family where they are. Again, we do come into situations very similar to what you described, where family members, everything that I'm seeing medically is communicating to me as a physician that this is a patient who is what we would say is moribund, but it's just a term we use to describe someone's illness state. How close are you to death, really? And I will look at that patient medically and I will say there is no way. And I have seen things reverse and patients surprise you all the time. So you should never count anyone out. But at the same time, there is, that's the rare example. That's the sort of rare examples where things flip around. And I think a lot of times, people are convinced that a miracle is going to happen, or that there's, their loved one is special to them. So they want to believe that something unique can happen here, and that the doctors are wrong, that everyone, none of us are seeing what's really happening. But, at the end of the day, if God is going to do a miracle, I can't stop that. I'm a doctor. I'm not in any position to stop God. And I just want to make sure that, the patients that we have that are looking for that spiritual support are able to get the spiritual support they need, whether that's us calling in their home, whoever their priest or their pastor is, calling in your own religious spiritual community, whether that's using our chaplaincy service. We have on-call 24/7 chaplaincy services available. And that's both palliative care and hospice care. I want to make that clear, but we have those services available. I think where people start to butt heads is when, things are changing very rapidly and we haven't had a chance to discuss, that this is where we are medically right now, where people have a hard time grappling with where things are, which is always a challenge. That's always a challenging situation.
Yeah.
So
It's tough. Yeah, it's tough, but I think this is a good spot, Dr. Mosely, to talk about advanced healthcare directives and why they're important for patients to have. Can you break that down for us?
Yeah, so a lot of the questions that have been asked this evening are centered around whether or not someone's voice is being heard, or whether or not someone's wishes are being met in the way that they felt is appropriate. And an advanced care document is one of the best ways that you can do that. It's effectively like a living will. That's a common term that I think people are more comfortable and familiar with than advanced directive or healthcare proxy, or, who do I pick for that job even? All of those are things. An advanced care planning document, though, should be it's a document that basically outlines what your wishes would be in the event that there was an emergency, or if your life were at risk of being lost. So let's say, for example, that your heart were to stop beating, or your lungs were to stop. If you were not able to breathe on your own and you're not conscious, in that case, would you feel comfortable going on a breathing machine? Would you feel comfortable with us placing a feeding tube if you don't wake up? Do you want IV hydration and antibiotics? Those are all the sort of things that we outline in advanced care planning documents. And while that's not a 100% fail-safe, in a situation where someone hasn't had a chance to talk about these issues with loved ones, whoever their healthcare support person is, then that still gives us sort of a window into what they might have said or what they might have thought for themselves before we go superimposing our thoughts, feelings, or beliefs onto that patient. And then that healthcare. Oh, sorry. Go ahead.
No. I'm listening. I was agreeing.
Yeah, I was going to say. Oh, but no. So a healthcare proxy or a healthcare representative, you might hear medical power of attorney. It's all the same term for the person that you would like to make decisions in the event that you're not able to speak for yourself, right? So most of the time, for example, if you're married, that would be your spouse, or if you have, if you're not married, that would be a parent, or if your parents are deceased, a sibling. But it's effectively someone who knows and has had this conversation with you on some level and is comfortable honoring your wishes and doing what they think would be most in alignment with what you would want for yourself if you can't voice that.
Okay. All right. I had a follow-up question, but you pretty much answered it.
Well, I wanted to just add that, you gave some great examples of who that could be, but you also, I think it's important that it's most importantly somebody that you trust, and also somebody who can advocate, right?
Right.
To make sure that your wishes are being honored. And that's not always your spouse. It might not always be your parent. It might not always be your child. But it just has to be somebody who you trust, for sure.
Yeah, and who we trust can change with time. So I mean, I've seen cases where it's exactly what you just said, Dr. Clark. A husband and a wife, they've been together for X amount of time. Wife made an independent decision not to go with the breathing machine, not to have chest compressions done, and her heart did stop while she was hospitalized. And because she had changed her advanced directives and told her husband, because it was less than 24 hours, the husband came in and demanded that they do exactly the opposite of what the wife said. And it was a very, very contentious firestorm, as you can imagine, because when the patient came to, she said, "How dare you disrespect my wishes?" And it was like, well, but we went with what your healthcare proxy said. And it wasn't necessarily the case that we should have trusted him to necessarily honor her wishes. So it is really important as someone that you trust.
Well, that brings up a really key question, which is just that very thing you mentioned. What happens if there is a difference of opinion and you've got the patient who has clearly followed the steps that you talked about, right? Documented it, had the conversation with their caregiver, but cannot speak for themselves. They have a proxy whom they have named, who it's known to the care team who the proxy is, and they don't agree with what's documented. How does that resolve itself? Is that turn into a legal issue?
So it can. It absolutely can. These are all, as we're talking, it's bringing specific patient cases to mind, because these are all very real issues that we deal with on a day-to-day basis. I think in general, that's the sort of thing that would go before, if the medical team caring for that patient wasn't able to make a solution or a compromise with a family that would be acceptable for everyone, then that is something that might be able to go, or it would need to necessarily go to our ethics committee at the hospital first. And then after the ethics committee has had an opportunity to review that, then, at that point, it really will depend on whatever their opinion is. Because I've seen cases where family members, it's, God forbid, this is horrible, but there was a case of elder abuse that we had recently. I actually just spoke at our biomedical ethics conference about this last Monday. And this woman and it wasn't her husband's fault necessarily, but he was neglecting her because he too was she had Alzheimer's and had a hip fracture, and he refused to let anyone else in the house and wouldn't let medical providers in. And it was actually like sort of a neglect case. So we actually wound up having to go to the ethics board and eventually petitioned to have her removed from the home, because it was very apparent that through no fault of his own, he couldn't care for her anymore, but also he refused to allow anyone to help, which that's clearly a difference of opinion. And I mean, if we feel that the patient's life is at risk, or we feel that this is a dangerous situation, then in that case, we would most likely make a recommendation to, either get this to the ethics board to help us facilitate that legal conversation around getting that patient conserved, or, if we can reach a compromise, that's really the desirable outcome. But those are extreme examples. But I think in a more, and I'm sorry if I'm rambling, please.
Oh, no, it's great.
No, but in a more, in a more general sense, though, there are disagreements and differences of opinion very frequently that we see. Someone doesn't want to get intubated, or they're done with the chemotherapy because the diarrhea that it's causing them is a side effect, or the nausea is just an unbearable sensation. And, they will want to come off of the chemotherapy, and they're more interested in looking at comfort-focused care. So that would be more through that hospice route that I was talking about before. No more treatment options, and we anticipate 6 months until the patient will pass away naturally from the disease course. But generally speaking, those are situations where constant open door communication is necessary, not just between the members of the family, not just between members of the medical team and the family, but amongst the members of the family as well. And in palliative care, complex decision-making and advanced communication is another thing that we focus on, so that sort of in a therapeutic environment, everyone has an opportunity to have their voice heard, everyone gets to ask questions, and it's a non-threatening environment where people can be vulnerable. Now, that process may take days. That is not something that's like overnight, Dr. Mosely shows up and then everyone's on the same page. Right. No, how I wish. It can be a days, weeks, months, sometimes years-long process, depending on what the level of illness is. It's always a challenge. That's always a challenge.
Yeah, and I wanted to highlight what you said about ethics boards, because I think a lot of people don't realize that hospitals do have these ethics boards to help resolve these very kinds of conflicts where it might be a little bit ambiguous. That's exactly what they're for, and it sort of leads into one of the next questions, which has to do with trust. How do you help patients get over the lack of trust that they won't get the best care if they have an advance directive, or if they indicate they want to be an organ donor? And this sort of goes back to, how marginalized communities have been treated, the lack of trust that Black people and other people of color might have in the healthcare, in healthcare in general. So that, I've heard any number of times, well, don't fill out that organ donor card, because, if something happens to you, you go to the hospital, they just gonna give up on you so that they can get those organs. Right. Or in filling out an advance directive, feeling afraid that, if I indicate this, that I won't get the best care because they'll just look at it and give up on me. So how do you address those issues?
That's a very deep question. But I thank you for asking it, because I think the organ donor thing, especially recently, I've been hearing more and more about that, and it's so funny. Not funny, haha, funny, but it's just funny that this is coming up. This is the second time I've heard this in the last week, actually, and it's an unfortunate misconception that a lot of people have about organ donation and the process in general. But no matter what hospital, I will say one thing, and it's applicable to every hospital in the United States of America: no physician and nobody that is on your medical team should be addressing organ donation with you at all, ever. Full stop, period. Organ donation is in and of itself something that is the process of the donation and the retrieval of the organs is completed through that's a completely separate organization. And ultimately, if someone has agreed to be an organ donor at our hospital, I can't speak for everyone, but we are trying to notify people in advance if there's the situation where we think someone's life is threatened. Your loved one was an organ donor, and this was their wish. They elected for themselves. We are not going to impose anything. We're not imposing anything. We just thought it's important for you to have this piece of information in the event that this becomes necessary. So it's all a part of it's pre-planning, it's pre-processing, but no medical professional involved in your loved one's care should be talking to you about organ donation, first of all. Second of all, I think going back to just the issue of filling out advance directives paperwork and thinking that you won't receive the same level of care, I think that it's a very unfortunate misconception. And in general, patients from marginalized communities, whether that's the African American and Black community, the Asian American and Pacific Islander community, Hispanic and Latino people, it doesn't matter. There is a prejudice that exists. and I don't think that's a secret to anybody that's listening to this conversation or participating in it. That's an open, dirty aspect of medicine. And I promise you, people like me are trying to fix it, but it's something that I think is going to take a lot of time, as it should, because trust isn't earned in just a moment. Trust is going to take years.
Because it took years to break down that trust. Right.
Yeah, we lost your microphone.
Sorry, it didn't get. Sorry, can you hear me now? Sorry about that.
Yes.
I accidentally touched the mute button, but no, you don't get. You're not necessarily destroyed. The relationship wasn't destroyed in a day, so you can't build it back or hope to build it back with wishes and dreams and happy statements here and there. We are going to have to make a concentrated. We need, as a medical community, to be making a concentrated effort to understand where every patient is coming from. And to some extent, I think medical education is trying to help with that piece. But I do think it's going to be some time before people have just implicit trust again. Insofar as advanced care planning documents go, though, I would hope that they're not a barrier, to people completing that documentation from fear that, we're just trying to kill you so that we can take the insurance money or something of that nature. That's something I've heard as well. No, but your advance directive is really, it's our opportunity to honor your wishes and to make sure that it's exactly as we've been saying. If you cannot speak, it's a way for your voice to still be heard and for you to let us know in some capacity what you would and wouldn't have been okay with. Like if I know personally, it's mentioned before, I'm 34 years old. I do have a living will, and it outlines all of those different things. I have advanced care planning documents because all of us really should. And making sure that having those conversations early.
Especially at your advanced age.
I'm basically geriatric at this point.
We ain't gonna mention your age anymore. We're not going to mention your age anymore. As the producer of this program,
it matters. If you think that family members don't fight in the room with their loved one who is facing end of life, and then somebody can bring out a living trust or an advance directive to squash that, it is hugely important. Take it from someone who has experienced it.
Right.
It matters.
Should that part about organ donation be in the advance directive document, and should that conversation be had with whomever might be around, because COVID taught us that anything could happen at any time?
Lord, isn't that the truth? COVID, God. I think that's something we may see, and something that's like a little peek behind the curtain. A lot of institutions are actually amending how we manage not just the organ donor conversation in the context of end of life care, but how we manage conversations about healthcare and healthcare proxy in general. So I think the step of just trying to disclose that someone is an organ donor in the event of an emergency, that's something that might eventually roll out into exactly what you just said, Karen, is us making people in the family or making healthcare proxies aware further in advance that the loved one has decided to be an organ donor, or, like a document just notifying, but again, it has to come from a non-medical care professional who's on the primary team taking care of your loved one. It has to come from another source. It has to come from the organ donation organization themselves.
Thank you.
Man, we are rolling with some great information, but it is that time. I can't believe it, that we need to bring in the audience to see if we have any audience questions in the chat. So what are you
Well, I
saying,
have a
Wayne and
question.
Lila?
I have a question from Paige Mays Rice. I think that's my
Okay.
mama.
Hey, Ma.
That's my mama.
Hey, Ma.
Since we're talking about advanced director, she says she's asking who is the keeper of the documents. Should the hospital be given documents at the time of admission?
That's an excellent question. And the answer is yes, please. If you have that documentation, please, if you are being admitted to the hospital or if you have it for your loved one, please be sure to bring that documentation in with you. Typically what happens these days in most hospitals that have an electronic health record is that that information will be scanned in, and then that document will be available in perpetuity to whoever is caring for your loved one or caring for you in the future. Now, if there's an update to it, here's the important thing. If you at any point update your living will or advanced care planning documents to reflect something different than what you had initially provided, that's when things can get hairy. So if you do make a change, make sure that you have an updated copy of the document readily available. Sticking it on your refrigerator is actually something we encourage patients to do when they are experiencing serious illness and they're requiring hospitalization. We actually encourage them to keep like a manila envelope or one of those brown like the folder. I can't think of what, my mother would laugh at me right now. I can't remember what this thing is called, but it's an envelope. And you put it on your refrigerator so that if emergency staff, emergency services have to come into the home, you can just grab that document right off of the fridge. Or some people like to print their documents out on bright pink paper, and then they leave that document somewhere very easy to find. And again, it's just so that everyone's on the same page, that information is available. And we also want to make sure that it's readily accessible to provide to medical staff at the time of hospitalization, or even a regular doctor's visit. That could be helpful as well.
So
we have all the Paige stuff saved on all of my electronic devices.
There you go.
Great idea.
So we have another question from, well, not her first question in a while. And it's from Tracy Walls, and was early in our conversation. Does the palliative care team offer services to caretakers and or family members?
So yeah, we actually do, and I'm really glad that someone asked this. So thank you very much. I can't remember the name of the person that asked the question. Tracy, thank you, Tracy, for asking that. That's a great one. So we do try to provide, especially in palliative care medicine, a lot of what we do, remember I mentioned total pain. Total pain doesn't just extend to the patient. It also is the stress and the burden that the caregivers for that patient are experiencing as well, because that's something that stresses the patients out, the family members are stressed out. And we refer to this generally as caregiver burden. So that is something that we are caregiver burnout. We're aware of that, and we do have services that are available to family members through palliative care, things like massage, Reiki, as I've mentioned before, acupuncture, depending on the setting, or talk therapy, cognitive behavioral therapy, bereavement services post-death. We have a lot of different services that are available for caregivers in addition to patients, because we're trying to care for the whole person, including whoever is caring for them.
And so how would a person access those resources, Dr. Mosely, a caregiver?
So you could talk to either primary care about, I want to ask a clarifying question. Are we assuming that this person that is the caregiver is being seen with the patient in the outpatient setting? Or in the inpatient setting, to be fair? Yeah, so I think just being direct and asking, saying, hey, I've been the one taking care of mom. I'm really struggling. I'm tired I'm tired in and of myself. I'm struggling right now, and I'm in need of a little bit of support. If you just address that statement or that concern to the palliative care provider that you're working with, in a lot of cases, they can make a referral immediately. And that's something that we pride ourselves on, is trying to immediately be of support to not just the patient, but their family as well.
Awesome.
Okay. Got a question from God's Girl, BJ Miller. Do the documents ever expire? Do the documents expire?
No. Nope. That is a great question. That's another. Everyone is asking such great questions today. So God's Girl. No, your advanced care planning documentation does not expire. But like I mentioned before, if you do have a change in your perspective, or you, let's say, are not interested in receiving more chemotherapy and you don't want to come back to the hospital, you're looking more at comfort-focused care, then at that point, you might want to make a change to your will. So then the old one would be null and void, and whatever you updated to would be the most accurate document. So always keeping that most accurate copy readily available and familiarizing yourself with what it entails so that you can be an advocate for either yourself or for your loved one.
Okay, I have a question for you, Dr. Mosely. What would you say to those superstitious people who think that talking about end-of-life care would somehow
We can't talk about that. We can't talk about that, Lau.
We don't talk about Bruno. No.
Right.
Right. You can't
We don't
talk
talk
about
Can't talk about that. No, this is a common, this is something I think that is common to every community. Now, this is something I have heard everything from we can't talk about that or don't. Some cultures actually will not even allow you to like in, I know in a lot of East Asian cultures, if an older family member will be ill and the family will request that you not share the information about the illness necessarily with the,
with the patient.
With the patient. So the patient may, in fact, I've been in that situation before. We had an elderly woman and she had a stomach cancer diagnosis, and her eldest son, who was her healthcare proxy, was like, don't tell her. Absolutely under no circumstances should you tell her that she has cancer. And, you know, those are challenging situations because if let's say that she is in terrible pain and she doesn't know why, that's a source of anguish. But now also here's this strange doctor who's telling me to take this pain pill that makes me feel queasy and wheezy. I don't understand what's happening here, right? Like that's always something that we worry about as patients. That's a challenge that's just a huge cultural challenge. A lot of times that I think people, it's hard as a provider to know how to really relate to that or what to do with that, because you want to communicate with your patient openly. But yeah, if the family and the patient have come to that agreement, then that can be a challenge.
I would also want to find out, where can somebody go if they're ready to put all of these wishes down on paper? Is there a place where we can get a template or a form?
So there's actually not, and this is a surprise, there actually is not a standard advanced care planning document, and there is no standard like a living will. So you see different versions of living wills. You know, and I'm sure Dr. Clark, you can probably attest to this as an ER doctor. You've probably seen it all. But yeah, they're very highly customizable. But who could you ask to get one, or who could you ask to help facilitate that? I would definitely start with your primary care doc, because, you know, honestly, the clinic that I worked in when I was a resident, we actually addressed end-of-life issues in advanced care planning for our patients that were over the age of 65. So that was something, you know, to be like, oh, it's time to get your cancer screening. And hey, by the way, have you ever thought about end-of-life care? You know, that there are documents that your primary care doctor will have available. And then, you know, in the event that you do need a referral to someone to help facilitate getting, you know, more legal paperwork done, then they would be able to facilitate that through the help of a social worker. Again, it's really just relying on your interdisciplinary team to have your back and give support where they can.
Okay, thank you. Oh, Dr. Mel,
we don't have a mic on you, Dr.
Hi there. Okay, so there's also a foundation called the Five Wishes Foundation, where you can go online and you know, they have templates there available. You can also talk to your lawyer too. If you have a relationship with a lawyer that you use, some people have prepaid legal. So if you have prepaid legal, you know, you could ask your doctor to help your lawyer to help put together advanced directive, or a quote unquote living will, as Dr. Mosely mentioned before. So a couple of additional resources. Do we have time for one more question?
Go ahead. The floor is yours, Dr. Mel.
Okay. Well, what is a healthcare advocate, and how do you choose one? Is that different from a power of attorney?
So honestly, this is a great question, and I think it really will depend on the institution that you are hospitalized and are being treated by. Generally speaking, healthcare proxy, at least in my experience, healthcare proxy and power of attorney have kind of, they've been conflated in a way that I think people think that they're exactly the same thing. But really, a medical power of attorney or legal power of attorney is someone who is legally granted the right to not just care for you, not just to make your decisions medically, which is what a healthcare proxy would be, but also to handle any medically related financial affairs that you have. And they would also have access to all of your healthcare information, things of that nature. So a power of attorney is it's that next step up from what a healthcare proxy would be. A healthcare proxy would be an advocate that could share with primary team members what you wouldn't want. And that power of attorney has the same abilities as a healthcare proxy, but they also have some further legal responsibilities and legal capabilities than just a healthcare proxy would have.
Wow. Well, Dr. Mosely, you have broken it down. You have gotten the congregation to say amen on any number of things. And you have just given the Be Health Empowered audience some wonderful information to go with. I just want to repeat that 5 Wishes Foundation, because that is like an immediate place that you could go to and download templates and start using them right away. If you want to start to fill out an advance directive, 18 and above, even years old, even younger if you want, because like you said, it's important to put these things down in paper because we don't know, right? Yes. So thank you so much for being here. Thank you, Karen Parker from the RCMI Community Engagement Car. Thank you to my wonderful co-hosts, Lila Mays and Wayne Bruce. Thank you, Wayne Bruce, for sharing that incredible experience with your sister. Thank you so much for doing that. And also, I just want to thank the Be Health Empowered family for tuning in and for always having just the on-point questions that we need to really make this show incredible. And until I see you again, remember, in everything, be wise, be well, and be health empowered. Thanks for joining us.